Welcome to this BTOG podcast. My name is Tom Newsom-Davis. I'm a medical oncologist at Chelsea and Westminster Hospital in London, and I'm the chair of the BTOG steering committee.
And I'm Emma O'Dowd. I'm a respiratory physician from Nottingham, and I'm a steering committee member alongside Tom. And this is part of our regular podcast series entitled BTOG Does, where we have informal chats with experts in their fields and tackle the most important questions we all face in the diagnosis and treatment of thoracic cancers.
Now, it's important to say that sponsors of BTOG do not have any role whatsoever in the planning, content, or delivery of anything we discussed today.
So welcome to this BTOG podcast on locally advanced non-small cell lung cancer with a focus today on non-resectable disease and looking at clinico-radiotherapy. I'm really happy to welcome Clive Peedell, who is one of our clinical oncologists, and we're going to talk through some aspects of unresectable locally advanced lung cancer over the next half an hour or so. So thank you for giving up your time, Clive.
Oh no, thanks Emma as well, giving up your time too.
So I thought what I'd start with is just basically talking about what we mean by unresectable disease. And obviously we have had a couple of other podcasts already within the locally advanced area looking at staging surgery and also talking about perioperative and neoadjuvant treatment. But there are generally what we're talking about is disease where either the patient can't have a surgical resection with a clear, what we mean by an R0 resection margin. So those are patients who are technically not resectable, but also we're talking about a group of patients who may not be resectable for a medical reason. So whether that's comorbidities such as lung function or cardiovascular disease. So it's actually a relatively broad group of patients. And a lot of those patients may well then come your way, Clive, in terms of clinical oncology treatment.
Yeah, absolutely. And it's the sort of MDTs these days, are really interesting. There's been a lot of changes, and as we know, stage three. If you just look at the TNM staging system, is an incredibly heterogeneous group, and it's just become more and more interesting over the years because the surgeons, are actually able to, potentially take on more complex cases. It wasn't so long ago when if someone had N2 disease, so any sort of mediastinal disease, then it would just go straight to sort of clinical oncology. And then we went into sort of the single station N2 era and giving neoadjuvant chemo. And now we're sort of potentially going to multi-station N2 as long as the surgeon thinks they can technically get an R0 resection. That's again that opens up quite an increasing number of patients. But obviously this is a group, as we know, it's smoking related disease for the vast majority of patients with lung cancer.
Yeah.
So there's a lot of comorbidity. So some of the patients might be technically resectable, but they're not medically operable. So that's a really key point. So the MDT is just so crucial these days in order to work up patients. So they get the appropriate referral. So I mean that's a big part of our job now, isn't it, at the moment?
And I think what's also been surprising to me is actually how much also radiotherapy, what you count as radically treatable, has changed even in the time that I've been doing lung cancer. And I think, and we'll touch on, I think later on some of the advances in radiotherapy techniques, but certainly I think what is deemed radically treatable now in the locally advanced setting has changed dramatically and continues to change as well. So I think a lot more patients are now being given the option of a radical treatment than they could have been 5, 10 years ago even.
Yeah, and I think that's absolutely crucial. I mean, it was only sort of about 7, 8 years ago when we had that sort of national audit report showing that probably only about 25% of stage three patients were being offered sort of radical treatment, which was, really quite, worrying to the entire community. We should understand that stage three is potentially curable disease. And I think that's a key learning point for today. Anybody facing stage three disease, the majority of patients are, potentially curable with that stage of disease. And we should be offering radical treatment if feasible and if the patient's well enough. And one of the great things BTOG's been able to do is raise awareness of that, very low uptake a few years back of patients, just getting palliative treatment. rather than getting radical treatments for stage 3 disease. And I'm really pleased to, say that actually, if you look at the National Lung Cancer Audit data coming out, we're up to sort of 60% of stage 3A and stage 3B patients being offered, radical treatment, even stage 3C patients as well. So I think raising awareness, especially with the Pacific trial data as well, with the big improvements in cure rates, I think we're really, pushing the forward in the UK now, which is brilliant.
And I think it changes how we have those conversations. So me as a respiratory physician, seeing someone at the start of that pathway, how you work them up and how you have those conversations is now very different. And the preparation that we have to do in terms of making sure these patients are as fit as possible is also very different. And I guess what we're preparing them for now is a sort of combination multimodality treatment. So when we're talking about this locally advanced setting, we're not talking about one single treatment for the majority of patients we're trying to treat radically. And I thought we would maybe start by covering sort of basics about radiotherapy strategies in terms of how you time things when you're talking about chemoradiotherapy, whether you're thinking about a concurrent or a sequential approach, and what those two things mean and what patients can expect.
Yeah, I mean that's a really really key point. So the modern standard of care is now seen to be concurrent chemoradiation followed by a year of immunotherapy with durvalumab. That would be seen as standard practice, but not everybody's fit for that. You've got to be really quite fit and in good condition, performance status 0 to 1 to get through like a modern sort of chemo radiotherapy regimen. It is tough going, but it's important to try and achieve that if we can, because at the moment, if you give sequential chemoradiotherapy, immunotherapy is not indicated, and the immunotherapy is giving an absolute survival benefit of about 10%. Therefore, we're trying to push people as much as we can to going down the concurrent route. It was interesting, a number of years ago we were having a debate whether actually concurrent was better than sequential, and it was actually quite marginal. And then the meta-analysis, the OPRAN meta-analysis, came out in about 2010, which showed about a 5% absolute survival advantage. So it's not dramatic. But now there's another 10% on top of that. So that's why it's important, if you can, to go down the concurrent route. I had been always a sort of fan of what was called the soccer regimen, because I was involved in that clinical trial. But that's quite a tough regimen. It's 55 gray and 20 fractions, which is 2.75 gray per fraction with cisplatin and vinorelbine. And that was really tough to get people through. But the RTOG 0617 trial, which we'll probably come on to a little bit, was a really important trial, which actually was a negative trial because it was trying to dose escalate from 60 gray to 74 gray, and actually
the idea that more radiotherapy is
exactly,
better.
yeah, higher dose, more radiation is better, but the bigger dose over a longer period of time, and with big cardiac doses, was shown to be actually detrimental. But what it did show is in the modern PET era, 5-year survival was around 30%, versus the OPRAN meta-analysis showed it was only about 15%. So that's why sort of PET staging's really important. So that was really a trial that actually showed it was if you went for 60 gray and 30 fractions, those patients were getting 30-odd% 5-year survival. So that has become sort of a standard treatment option now in the UK, to give between 60 and 66 gray concurrent. And you can, instead of giving cisplatin, you can give carboplatin. And we give a weekly carbotaxol type regimen, and that's actually better tolerated than trying to give cisplatin concurrently, which is, like I say, a really tough regimen. So there are lots of things we can potentially do to get people through this tough regimen.
And what proportion of your patients now do you think you're able to actually get through that concurrent stage so they're eligible for their durvalumab afterwards?
Yeah, I mean, it's difficult to say exact numbers because we're still getting sort of palliative patients, or more palliative patients coming through who are really quite frail. But I'm probably getting about maybe 50-50, concurrent versus sequential chemoradiation. which is, we're pushing it, much harder than we used to. That's not bad for somewhere like, Teesside where I work, where there's a lot of medical comorbidity. So basically, they've got to be PS 0 to 1, And if some of them are not even fit for sequential chemo radiation, but I still give them radical radiotherapy. So you should still offer radical radiotherapy if someone's not fit for chemo as well. I would also make that point. Some of those patients can still do, reasonably well. But if you can, try and get the if there's performance status 0 to 1, they should be going down that sort of concurrent route. Sometimes there's big volume disease. And if there's big volume disease, then you can consider giving a couple of neoadjuvant chemo cycles up front to try and shrink the volume down. And when you're doing your planning as well, sometimes you look at a volume and think, oh, we're never going to be able to give that radical treatment. But it's only when you've actually done the planning and done, done the dose constraints to see how close you are that you can make those decisions. So I often say, look, plan and see. And sometimes you can adjust your volume. So if the volume is a bit big, then you can go back and you can make some adjustments to your sort of clinical target volume and the sort of margins that we go around the tumor. And that's something to bear in mind. And the other thing you can do is the Pacific trial. It didn't go into great detail about the sort of the radiotherapy regimens, and actually, when they quoted what doses were given, they went down to 54 gray. So if you need to drop the dose a little bit in order to get the concurrent treatment in, then you can drop the dose down to 54 gray from 60 gray. So that's another option to allow us to get these sort of treatments in. So there's lots of different things we can do. And the other thing to do is obviously a bit of prehab as well, try and get patients a bit like they do in surgery, do some, prehab, even a couple of weeks, sitting, standing exercises, just getting up and down like this. It looks crazy, but standing up and down, I'm sure you
just for people that are listening, Clive's doing some prehab at the moment
yeah,
on the podcast.
I'm sitting and standing in from my chair at the moment. So just some simple exercises, really important to speak to patients about.
And I think the preconception often is this patient is not fit for surgery, but they can go through concurrent chemoradiotherapy. And actually, I would argue it's more of a hit to try and get someone through that. So actually, prehab is almost more important, and particularly with dietetic support, because often these patients can suffer, and we're going to talk about toxicity, I think, a bit later, but trying to make sure that you can get them through that treatment can be really difficult without additional input from the other therapy teams, I think.
Yeah, and that's absolutely key point. I mean, you really need a good team looking after the people, and you've sort of hit the nail on the head with sort of dietetic advice as well. That's really crucial because often we're talking about, mediastinal disease. So obviously the esophagus runs right down the middle, and therefore the esophagus can get quite a dose. And so esophagitis is one of the sort of dose-limiting toxicities that we see. As it happens, we rarely have to admit people for feeding, but that is a possible that some might end up with NG feeding. But even if that isn't the case, they can really run into severe problems with getting the right amount of food down and losing weight, all those sorts of problems. And because the course can be a 6-week course, you don't want to have dramatic weight loss because that could affect your planning if people are not setting up properly, because they can actually slightly change position if they've lost enormous amounts of weight. So that can actually affect your, radiation delivery, believe it or not. And obviously it's going to affect, if they get infections, if they're not well nourished, they can, really end up more likely to get pneumonia and other sort of complications. And obviously, if you're feeling tired, washed out, people often get sort of muscle loss as well because they're not exercising. So all of those things, are going to make patients more likely to become less mobile, more risk of getting thromboembolic disease. All of these sorts of things are really important to bear in mind when they're having their treatment. So, those things, really are key. So I give a prophylactic PPI as well. To reduce the risk of acid reflux, because if you've got a sore gullet already, you don't want acid on there. So those sorts of things can be, quite helpful as well.
So we've sort of talked about how Pacific has really transformed that care for those people who can go through concurrent chemoradiotherapy, and I think the reassuring thing is the longer term survival data that have been published actually from Pacific have been really encouraging, haven't they, in that sort of updated analysis? But what about the sequential population? Is there kind of hope that they can be able to access some of the immunotherapy? Do you think in terms of additional Pacific trials?
Yeah, no, I think that's really important. So obviously the Pacific trial itself, I think is 43% 5-year survival, which for stage 3 disease is, pretty remarkable.
Yeah.
When I've been a consultant 20 years, and I used to quote people, you've got about a 15-20% chance of, long-term outcome. And to be able to say it's above 40% now is amazing. And that was a 10% absolute survival benefit. So when oncologists see a 10% absolute survival benefit from a new treatment, it is literally jaw-dropping. But obviously, that's, as you say, that's just for concurrent. So what about for sequential? So, I mean, that's on the horizon, I think. The Pacific 6 trials of sort of phase 2 study, single arm study that is looking at exactly that question. And the phase 3 arm will be in the Pacific 5 study. So we do need to wait for the phase 3 data, but the phase, 2 data is really encouraging. They're basically getting the same outcomes as we saw in Pacific. So the sequentially treated patients are doing just as well as the concurrent treatments. Obviously, it's a slightly different population, and we can't compare, like with like necessarily. But I think that's, really encouraging. Where there is another interesting approach is to give immunotherapy at the same time as the radiation. So they tried that in Pacific 2, another trial, another Pacific trial. There's lots of them. We're up to 9, I think, at the moment now. We'll come on to that a bit later. But that's really important because it's not just that trial. There's been a few trials now, a number of negative trials. You shouldn't basically give radiation with immunotherapy at the same time. And that sort of makes sense to me, though, because radiation is brilliant at killing white cells. It's basically a really good anti-inflammatory, but you don't want an anti-inflammatory. It's like high dose steroids. You don't want to give high dose steroids when you're giving immunotherapy. So you don't want to be giving radiotherapy at this concurrently with immunotherapy. And basically that showed that wiped out all of the survival advantage of giving durvalumab when you gave it concurrently with radiation. But this is really useful information. We need this data to know how to sequence everything, So we're still learning a lot, but it seems to be it's best to give it, afterwards and, maybe even beforehand, but don't give it at the same time. So we are learning a lot more as time goes by.
And we always worry as well, I think, about trial populations, and actually you then look at your MDT and realize that probably nobody is like the young, relatively fit clinical trial population. So do we have anything to suggest that actually in the real world we're able to achieve equivalent outcomes to what we do in the Pacific trial in these populations?
Yeah, I mean, this is like a real trendy thing now, isn't it? All the real world data, and actually we've got loads of it now. So it's actually really quite encouraging. So quite a few areas, just from doing the poster work at BTOG in the last couple of years and going around. There's loads of centres that are publishing their Durva data, so keep it coming, and it's really high quality, and it's showing pretty much, the same results as the Pacific trial, which is remarkable considering a lot of the sort of postcodes that we've got around the country. We've got some real world data from the Pacific trial. The Pacific R trial has got some real world data, but probably the best data we got actually is from the Cancer Drugs Fund. So that's just been published, about 600-700 patients. They just got from the CDF database, and they did just as well as the Pacific data. In fact, I think it was 1 or 2% better. So actually, in the real world, we are selecting patients correctly. We're giving the right patients the treatment by the looks of it. So I'm really encouraged by that. And I think that's down to the sort of BTOG community and the way we've raised awareness as a group to educate the whole country. And it's really encouraging. I think we're doing really, really well as a nation.
And I think it's about confidence as well, isn't it? It's the same in that sort of neoadjuvant perioperative era when things start, you very careful, and then you see people come through. And I think the same is true now in certainly people feeling confident giving concurrent chemoradiotherapy followed by immunotherapy, because you see how well people do if you can get them through that initial concurrent phase. So I think it is about feeling confident and then seeing how well patients are managing afterwards as well.
I think that's absolutely right. And, people were a bit scared of giving concurrent treatment. I totally get it. But I think, like I say, we've had a great educational push from, the community, and the way the trainees are trained as well, getting used to seeing these patients, and also managing immunotherapy toxicity as well. I think the whole educational system is really, really good, because that's another thing to mention. Obviously, is that there is toxicity from, durvalumab, and about sort of 15-20% won't complete the course. So I mean, that's important to bear in mind. There's still some toxicity, but the data's still there. We're still doing really, really well. And if we can, if people do have to stop, they have to stop. But there's still many of those will still be getting benefit from that treatment, even if you have to stop it. We know in the stage 4 situation, if people get toxicity with immunotherapy, they can still get a lot of benefit from the immunotherapy, even if they have to stop it. We've all got anecdotal cases of giving one cycle of immunotherapy, having a nightmare with toxicity, stopping the drug, and actually the cancer not progressing. And you're 3 or 4 years down the line, you're giving it, wow, we only gave them one lot. So it's important to get the treatment in, but obviously it's important to be brave enough to stop it if there are complications. And pneumonitis is a particularly difficult issue, because obviously we get radiation pneumonitis. So how do you tell the difference between radiation pneumonitis, which occurs classically sort of 2 to 10 months after giving the radiation, and the pneumonitis caused by durvalumab? So again, you just treat it with some steroids and you see how you get on. And if you get a grade 3 toxicity, and if you end up admitting someone, the bottom line is you would stop the treatment at that point. Whereas if you get a mild toxicity that you can control as an outpatient, you might be able to restart the treatment and maybe adjust the dose. But the important thing is to at least start the treatment and see how you get on with it.
And I guess that leads us nicely on to talking about kind of short and long-term toxicities. You mentioned obviously pneumonitis is always a concern. You've also mentioned esophagus, and I guess your modern and ever-advancing radiotherapy techniques allow you to try and minimize those doses to the organs at risk, which I guess is what drives a lot of the toxicity in the early phase of treatment.
No, absolutely. And we mentioned about the RTOG, 0617 that went to that 74 gray, and that's been looked at in detail since. And actually, Corinne Favour-Finn's done quite a bit of work on this study, actually looking at it. And it seems that the cardiac toxicity, because the doses the heart were getting were really quite significant in this study. And it's probably cardiac toxicity and probably with a bit of pneumonitis that was increasing the toxicity. There was about an 8% survival difference between the two arms, so it really was toxic. The survival curves are sort of coming apart at about 6 months. So I think this is sort of cardiac and cardiorespiratory toxicity. And that's a big area of focus at the moment in radiation oncology, is especially around cardiac toxicity. A lot of work's being done on that. It's a really complex organ, the heart. We don't really know enough about it in terms of the dose constraints, and lots of different studies have looked at the sort of mean heart dose, or what about the coronary artery dose, and what about the dose to the sort of conduction system. It's so complicated, and we're really still learning in this area. And I think that there's a whole area of cardio-oncology that we need to look into, and we should probably be talking to our cardiology colleagues regarding these patients, and having a workup pre, during, and post treatment. And I think the future trials are going to be looking at that, seeing if we've got some good biomarkers, cardiac biomarkers. Obviously we've got our ECG, but can we use some more fancy molecular markers and proteins to look at pre-post treatments, and work out who's going to be at risk, and then mix that with the big data that we can get from our physics guys, because they can get really detailed data about how much dose the heart's getting, which bits of the anatomy of the heart are getting the dose, and if you can correlate that to outcomes with big data, that would be really important. And that's where there's some brilliant work again coming out of the Christie. They published some really important stuff that was award-winning stuff at Estro a couple of years ago, showing the cone beam corrections of when you're correcting the position of the patient to deliver the radiation. They showed that if you corrected towards the heart rather than away to the heart, actually there was a higher mortality in that group of patients. So basically, shifting towards the heart was actually, causing a higher mortality. So that was a really, again, insightful bit of information that is sort of going to be built in, hopefully, to clinical trial design in future. So it's a fascinating area of research.
And I guess it's positive in that these patients are living long enough now to experience a toxicity that perhaps wasn't on the radar before. But as a sort of slightly stupid respiratory physician, how can you change your radiotherapy to try to minimize that dose when you have quite central locally advanced disease? What sort of advances are there now in your radiotherapy techniques that allow you to be able to bend your beams in whatever direction?
No, that's great. Yeah, we need your help with the long-term follow-up. Absolutely, we need you and the cardiology guys to help us. But actually, we can help ourselves by being more accurate in treatment delivery. So the key developments are obviously developments like image-guided radiation, so that we can actually do what's called a cone beam CT scan and match that to the planning scan to make sure the patients are in the correct position. That's allowed us to reduce margins over time. And then obviously intensity modulated radiotherapy has been proven to reduce toxicity now for patients. And basically, what intensity modulated radiotherapy, the best way to think about it, as you say, although we don't literally bend beams, it allows you to basically treat concave structures. So with just normal conformal radiotherapy, you just sort of have convex shapes, but with IMRT, you can literally have concave volume, so you can wrap your dose, if you like, around structures like the esophagus. You could avoid coronary arteries if you needed to, for example. And we can now do dose painting as well, literally, dump high dose where the tumor is and then have low dose areas where you've got critical normal structures around. And we've also got technology like four-dimensional CT scanning. So basically, you take a movie of when you do a CT scan, and so you take account of respiratory motion and sometimes even cardiac motion with some of the modern bits of kit to deliver the treatment. And some of the other developments are what we call online adaptive radiotherapy. So obviously with central tumors, sometimes you get a bit of atelectasis lung collapse, and then suddenly during treatment, a bit of lung reinflates. And you can imagine if the lung re-expands, that's going to shift all the anatomy. Currently we would just replan the patient, so they'd have a delay of a couple of days whilst you replan the whole thing. But the modern online adaptive radiotherapy literally allows you to draw your volume on the screen at the sort of monitor where the patient's being treated. There's a recalculation. It's really fast. So literally within minutes, the patient can restart their treatment after you've sort of literally replanned them on the unit. It's really cool. It's ace being a radiation oncologist.
I'm actually quite interested, Clive.
Yeah,
You've done a good job of selling it to me.
It's not too late to change your field, Emma. But yeah, like I say, you've got too much important work to do as so much ace stuff going on in respiratory, as you well know.
Everywhere's
and
exciting.
let's never forget the most important thing is about smoking cessation and public health.
Absolutely.
We should never forget that, because you can have all the lovely technology you want, but actually, if you spend, you get much more, result from your spending if you put it into public health.
Exactly. So if we think now about those patients who actually have a targetable mutation, so perhaps we could start with EGFR. Is there something that we can do in terms of adjuvant or sort of post chemo radiotherapy treatment for the EGFR positive population at the moment?
Yeah, I mean that's a really key point. Obviously, I'm seeing more and more driver mutation patients, because we've got much better pathology systems now, and picking up mutations much more frequently. So it's maybe about 10-15% of our population are going to have those slightly more common mutations. So EGFR and ALK to a lesser extent, and actually, in the Pacific trial, they did include those patients actually, but obviously it was a small percentage. And they did a subgroup analysis, and they've shown actually no discernible benefit from durvalumab in this patient group. So the durvalumab didn't seem to work, which is sort of in keeping with immunotherapy not being particularly effective in the driver mutation, population, EGFR and outpatients. So it's you can give so if you, the standard practice is still potentially, if you wanted to, you could give durvalumab to an ALK or a EGFR positive patient. I probably wouldn't. I just don't think it's going to be of benefit, and I think there's obviously a risk of toxicity from doing that. But obviously on the horizon, I think we just need to wait for the funding. It's going to happen, hopefully. But obviously, we had the Laura trial, which was, obviously gave osimertinib post chemo radiotherapy in stage 3 in exactly this type of situation. And, the progression-free survival is, fantastic, as we would expect. But the overall survival, we need to wait for it to mature. But at 3 years, there's a 10% absolute survival benefit. So, I think it's a no-brainer. I think we're going to be going down that route. And interestingly, there is a trial called the Horizon 1 trial, which is now looking at alectinib in the post chemoradiotherapy, both in the sequential and the concurrent setting. And there's even a subgroup that's looking at ROS1 mutation with entrectinib as well in that same study. So that's going to be it's recruiting reasonably well apparently. And I was just looking it up on an AI engine today, and apparently it's going to finish recruiting in 2029. But I don't know how much we can trust these things. But absolutely. So we've definitely got new areas from that perspective.
So we can combine our chemoradiotherapy with then a targetable therapy potentially afterwards.
Absolutely. So instead of giving Durva, you'll give OSI, for example, with EGFR. Interestingly, that's sort of like until progression, so you can give it indefinitely, which is an interesting question actually, because if you're giving a curative treatment, do you really want to be giving these drugs indefinitely? So it will be to clinician discretion, and I think this would be something we'll be having chats at and debates at BTOG in future about, how long should we give the OSI for in this situation. Anyway, that's for we have to wait for it first to potentially get funding.
Still an emerging field. So
it's an emerging field.
If we're looking then forward at the kind of horizon, just as a sort of final thinking about things, what things do you think are on the horizon for this group of patients from your kind of perspective?
Yeah, so obviously we're still looking at radiosensitization. So some great work going on in the UK actually from the Concord trial, so led by Jerry Hanna and Alistair Greystoke, my mate up in Newcastle. So that's looking at DNA repair mechanisms, drugs interacting like PARP inhibitors like olaparib, but a few other drugs. And that's a really interesting sort of platform study looking at a number of different drugs in a number of different arms on that trial to see how well they're tolerated. That's a phase 1b trial, so that's exciting. And I'm into stereotactic radiotherapy. I really like the idea of that, and in selected patients we might be able to be using stereotactic radiotherapy. And there's literally just at Astro just been orally presented as a study called the new era, Start New Era it's called, and that was I believe an Italian group that was looking at giving 45 gray to central tumor and then 40 gray to the lymph nodes, so not given concurrently. These are in patients that weren't fit for concurrent chemoradiation, but they were getting excellent local control rates. So how we integrate stereotactic radiotherapy with this whole type of chemoradiation approach would be interesting as well, because you could do something called hybrid radiotherapy, where you sort of the primary tumor might peripheral, so you could give that a big whacking dose and then give a much lower dose to the central structures, which are near the critical structures like the heart and the esophagus. So there's so much to learn from new approaches like this. So that's going to be a focus of research as well. So basically, it's an incredibly exciting field. It's an incredibly complex field because it's so heterogeneous, as we know. But I think we're making really good progress, and hopefully we'll all be able to get involved in some of these ongoing clinical trials.
And I think that's really important to say, isn't it? Is that actually there are lots and lots of clinical trials open, and it's really important that we provide patients with access to these clinical trials so that we can give them the best access to treatment, but also learn about what we need to do moving forward.
No, absolutely. And one other trial, obviously Pacific 9 is the other trial as well. So that's bolting on a couple of other drugs to Devalimab. So that's got three arms. It's got the Devalimab control arm, and then there's Devalimab and Aleclamab. I can't say the word, and Monalizumab. I'm not very good with the names of these new drugs. I might have said those wrong, but people can look up the protocol. So lots of like interesting developments.
It sounds like it's going to be a really exciting field moving forward. So I guess if I'm to kind of try and summarize at the end things that we've sort of learned and I've learned, I guess it's that concurrent chemoradiotherapy is really the backbone still for fit patients. But we know that actually dose escalation is harmful for these patients in terms of radiotherapy. We know that Devalimab consolidation now adds a durable survival benefit, which is confirmed at 5 years. And we've got real world UK data that show that we're able to deliver this in UK practice. And we do have some hope for those with EGFR and other targetable mutations. So through the LAURA trial and other trials that it sounds like are trying to look at consolidation targeted therapy after you complete your chemoradiotherapy, and toxicity, particularly cardiac and long term, is an issue, but we're able to start managing that with extra knowledge and also advances in radiotherapy techniques. And it sounds like a lot of these ongoing and future trials are going to be able to refine these combination strategies and look at what long-term safety profiles are. So that would be my kind of summary of what I've learnt. And so thank you, Clive, for taking the time to go through it all. I think it's been incredibly helpful. And I'm sure if people have got questions, you'll be available on the dance floor at the BTOG conference next year.
It's best place to find me. Well, maybe not the best place.
But no, thank you everyone for listening, and I hope that this has been really helpful in understanding where we are today in terms of unresectable non-small cell lung cancer and where we may be going in the future.
Thank you for listening. We hope you enjoyed this podcast. For more information on BTOG, including educational events and how to join, of course, you can visit www.btog.org. Just to remind you, we would love to hear your comments, thoughts, questions about things we discussed. And for the really interesting ones, we'll even discuss them in our next podcast. You can contact us on info@btog.org or on Twitter @btog.org. Thank you very much.